Presenting on behalf of Medicine 2 under the topic of the inflammable mimic. Presenting Mr. S, a 49-year-old gardener from Hosur, who came to us with low-grade fever without any chills and rigor, which was an intermittent fever, relieved with some analgesics, antipyretics for 2 months, and acute history of altered sensorium for 1 day. There was history of loss of appetite, loss of weight of about approximately 7 kg in the past 1 month, and he was complaining of some swelling over the right side of the neck 1.5 months back. There was no associated cough, breathing difficulty, no vomiting, no loose stools, no reduced urine output, no headache or bowel or bladder disturbances. He's a known diabetic for 7 years on medications for the same, but was uncontrolled diabetic. He was evaluated 1 month back for the right-sided neck mass, which was a lymph node, biopsied and showed it was granulomatous inflammation. In suspicion of a TB lymphadenitis, they had started him on ATT for 1 month. And later, they had also thought of, the biopsy was reviewed by 3 people. First, it was reported as a granulomatous inflammation. Second time, they had reported as multiple epithelioid cells suggestive of malignancy, but the definitive why they thought of a malignancy was not mentioned. So they had stopped ATT at that point of time after a month. And on 5th of September, he had some reduced urine output and vomiting, was admitted in an outside hospital, received 5 days of meropenem, piptas and amikacin. He had improved for 2 days, but then persisted to have fever spike after discharge and then brought to CMC for further management. And in between this period also, from 18th to 23rd, he had another acute febrile illness kind of a picture, and the hyponatremia as well. So another significant past history is that there was some injury to the left foot 12 years back, for which reconstruction with the flap was done. He works as a gardener 15 days a month. Because of this injury, he was not able to stand for a long time. But for the past 2 months, in view of the illness, he's not been working also. He's a reformed ethanol consumer, but no history of any smoking. On examination, he was a middle-aged gentleman, disoriented but not in any distress. BP was 170, pulse rate was 130 per minute, but he was breathing at 22. GCS was 9/15. There was pallor with bilateral, cervical and axillary lymphadenopathy. The rest of the systemic examination was unremarkable. So in this situation, a fever with loss of weight, loss of appetite, we were approaching like a PUO. The top differentials that we thought because of generalized lymphadenopathy, infections like TB, HIV, and considering uncontrolled diabetic, we also thought of fungal infections. Other possibilities could be because he's a middle-aged gentleman, though autoimmune disorders are rare, we also thought of SLE and vasculitis-like disorders or malignancies like lymphomas and leukemias. So baseline investigations revealed anemia, thrombocytopenia, but with normal counts, neutrophils of 85%, lymphocytes of 10. There was eosinopenia, eosinophils of 0. And urea was 53, creat was borderline high, 1.56. The LFT had shown hypoalbuminemia, mild SGOT elevation, and mild alkaline phosphatase elevation. Electrolytes had shown hypernatremia. This was the cause we attributed to the altered sensorium, probably because of hypernatremia overcorrection from outside hospital. He was, we thought it could be metabolic complication. Calcium, phosphate, and magnesium were all within normal limits. We were working him like a PUO. We had sent blood cultures, ESR, CRP. The workup for a PUO was entirely sent, in which on the next day we found that his anti-PR3 was 39, but MPO was less than 2. He had a granulomatous inflammation on an outside biopsy. With anti-PR3 positivity, we were thinking it was probably a vasculitis. With bicytopenia, mild creat elevation, we were thinking probably because there is some renal involvement. So we were working up in lines of what were the organ involvement in a vasculitis. Urine routine had shown only 2 to 3 RBCs. There was no hematuria, but there was proteinuria. There was no vasculitis, skin rash. He did not have any hemoptysis, but he was having generalized myalgia. He did not let us move the shoulders. There was bilateral shoulder arthralgias. ECG and echo was normal. Though the anti-PR3 had come positive, there was no definitive evidence clinically to suggest that this was a vasculitis. We did also a bone marrow because patient was having worsening cytopenias. From bicytopenia, patient had gone to a pancytopenia. That is when we found that the bone marrow aspirate had shown HLH, predominantly erythrophagocytosis. So again, there was a thought that whether it is a vasculitis causing HLH, and HLH workup wise, ferritin was elevated, fibrinogen was low normal, triglyceride was 220, there was fever, there was no splenomegaly, bicytopenia had progressed to pancytopenia at this point. The H score was 220, which was highly suggestive of a HLS. So we were almost convinced that it's most likely a vasculitis that is causing a HLH, and we were planning to initiate the patient on pulse therapy after culture negativity. That is when, to our surprise, that the cultures had grown Burkholderia pseudomallei. All three cultures and bone marrow grew the same organism, which was melioid, and we are waiting for it to be confirmed biochemically. We have discussed with the lab. They have told that it is Burkholderia pseudomallei, but to confirm, they will take another 2 days because they have to run few more biochemical tests, it seems. So this is a frank case of melioidosis with HLH. But then why was ANCA positive? That was our question. So what is I would want to outline on the false positive ANCAs and a case report of melioidosis with HLH. So ANCA positivity in our lab is reported with indirect immunofluorescence and ELISA. The specificity of ANCA for vaginous granulomatosis goes up to 99.99%, which means false positive is very, very, very rare, which our patient had. So this is another article where 40 patients with positive C ANCA, but there was no evidence of any ANCA-associated vasculitis. The most common was 20% infectious diseases, which our patient had, a melioid, and other diseases like IBD, CVA, uveitis, ILD. There are a list of other causes that can cause a false positive ANCA, but always to be kept in mind that ANCA is 99% specific, but in our patient, there was no clinical features to suggest a vasculitis. In this scenario, the ANCA positivity has to be taken with a pinch of salt in mind. The other infections that can cause a positive ANCA are H. influenza, Mycobacterium bovis, Mycobacterium tuberculosis, Porothrix, and Staph aureus. So there are few case reports of melioidosis causing HLH. I would want to highlight one of those cases, which was almost closely resembling our patient. This was a 58-year-old lady who came to the hospital. This was a case report from Australia with low backache, confusion, worsening pancytopenia, and features suggestive of HLH. They also, on the day 2 of diagnosis, found that the blood cultures had melioid. Despite therapy, adequate meropenem therapy, she had succumbed to death on day 41. So they had reported that the mortality rate of melioidosis with HLH is almost about 40 to 50%. And in our patient, we initially, when the patient came itself, he was having low-grade fever spikes, but because he was treated in an outside hospital and referred, we had started him on meropenem 1 gram IV QATH. Once we got the cultures, we had upgraded it to meropenem 2 gram IV QATH as an infusion over 3 hours. Patient still has low-grade fever spikes, but is showing signs of clinical improvement. The hyponatremia has resolved, the sensorium is gradually improving, and the fever spikes also are coming down. We are waiting for a culture negativity. We've sent repeat cultures, and after the patient becomes well, we are planning to continue to change it to a continuation phase with 6 weeks of septin. So our learning point is, although C ANCA has 99% specificity for vaginas, it should be reviewed with the context of overall clinical picture, and inappropriate diagnosis only based on antibody testing could have serious clinical consequences. If we had pulsed this patient, we would have lost him. Thank you.
Yes, I'm saying really thrilled to hear the clinical presentation. What's the drug of choice for melioidosis now?
We give meropenem as continuous infusion, as an infusion over 3 hours at 2 gram IV QATH.
I'm aware of a few publications from CMC with melioidosis some time ago. I don't know of late how it's been keeping up. Do you think, so there seems to be the question here you raised was, could this be vasculitis, etc. was the underlying. Do you think this patient is telling us there is overactive innate immune response or adaptive immune response? What is your case telling you? Can you tell me 1 or 2 cells in the blood which are part of adaptive response and which are part of innate response?
T cells and B cells are adaptive immunity.
T and B cells are adaptive. Very good.
Innate immunity is NK cells, dendritic cells.
NK cells, dendritic cells, even neutrophils. Okay. So histiocytes in the tissue, etc. So that's probably what you're facing here. So what is the term hemophagocytosis refer to? Adaptive or innate? Hemophagocytosis. Innate immune system. So innate immune system, for example, the phagocytes are eating up the RBCs. That's what the bone marrow showed here. Similarly, you said ANCA is positive. Neutrophil is innate or adaptive? Innate. So what you're facing here is an overactive innate immune response, which is throwing up what you think is false positives. But there's infection, and the body is immediately mounting on innate immune response, which is what you're picking up here by the test. Very interesting. Any other comments, anyone?
How are you planning to follow up?
Currently, patient is admitted in ward. So after, like, once the patient is stable, we will plan on discharge, and 2 months, 6 weeks of septrin therapy is the plan. Yeah, the case report, the studies have also told that after the infection settled, the serial follow-up of ANCA after 2 months will be helpful in ascertaining whether it was true vasculitis or not.
What ANCA was positive?
C ANCA.
The criteria to diagnose prejudice. You should understand certain diseases in medicine have criteria because they don't have a specific test. So CANCA is not a specific test. So if you end up finding it in many other diseases, it's just a random finding. Did your patient have the other criteria to be met, which would have actually put him into your regimens? No. And your patient was not sensitive to septicity. Was he sensitive?
Sensitive to septicity.
It's better to actually downgrade to septicity.
Sure.
Ceftazidime used to be the drug of choice. I wondered whether it moved to Miro now. Another question I had: can this lymph nodes be attributed to melioidosis, or is it only a blood infection, bacteremia, and fever, or can you get node levels in melioidosis?
These are all very subcentrimetric lymph nodes, sir. Probably reactive lymphadenopathy is what we are thinking.
Actually, it can. In fact, that was in publication from CMC. There is a series of melioidosis which was reported by the surgical department. So they end up with surgery for a medical bug causing the problem. Okay, that's the interesting thing. So you can have lymphadenopathy or some other organ involvement and end up with a surgical presentation. That's what.
Thank you, sir.